Hey there, thank you for tuning into this video. I am Prabuddha Goswami and today I'll be teaching you pharmacokinetics. Now this is the second lecture of the series on general pharmacology, and I would request you, just for continuity's sake, you check out my previous video as well. So without wasting further time, let's get started. So what will we be learning today? Now see, pharmacokinetics as a whole is a huge subject, right? We know, and so because we need to choose what we need to study and what we need to leave out, so I have specified in my discussion today only topics which are relevant from the examination, that is both the theory and the viva point of view. So you can see these our will be our learning objectives today, and so let's get started. So first of all, as we know, what is pharmacokinetics? Like I also mentioned in my previous video, pharmacokinetics is the effect of the body on the drug. Now it is also called as ADME study. Now what does ADME stand for? As I've already told before, A stands for absorption, D stands for distribution, E stands for metabolism, and E stands for elimination of the drug. So after we have any, after we administer or ingest any drug, what effect does our body have on that particular drug is what pharmacokinetics is all about. This is a very big, this is a very good, schematic distribution of the pharmacokinetic processes. This is a chart which I have taken from K.D. Tripathi, and which shows us the various phases of pharmacokinetics where the drug is being absorbed, the drug is being distributed, and the drug is being excreted after it is being metabolized, and it is after it is forming metabolites, and these metabolites are being excreted via urine, bile, feces, and saliva. Okay, so as you can see, it is being excreted via the metabolites. After the drug has been administered, the metabolites are being excreted from our body. Okay, so this is a very important topic, bioavailability. This is given as both a short note and a long question, and as a part of a long question, I beg your pardon. So what exactly is bioavailability? The fraction of a drug which enters systemic circulation from an administered dose. So after we take in a dose, the fraction of that particular dose of the drug which is entering systemic circulation is what bioavailability is all about. Now, as we know, if two drugs have the same bioavailability, with the parlance of English, we can say them to be bioequivalent, right? And if not, they are said to be bioinequivalent. Now, what is very important to note is that the bioavailability of drugs administered via the intravenous route is 100%. That is, the entire amount of drug that you administer via intravenous route is getting biometabolized, or is being channelized into our systemic circulation. Okay. Now, one more question which we are often asked in our exam is, how do we find the bioavailability of an orally administered drug? Okay. So this is a question which you find as a part of your long question. So see, what we'll do is very simple. First, we will draw a graph which tells us the plasma concentration of the graph. Of the drug with respect to time. Okay. So we'll have the plasma concentration on the y-axis and the time during which we have administered the drug on the x-axis, and with that we will plot two graphs. And what are these two graphs? The first graph will be the plasma concentration versus time curve when the drug that we whose bioavailability we want to find out, right? We administered that drug via the oral route. Okay, this will be our first curve. As you can see, PO is the oral route, and the same drug in the same dose, okay, we administered but via the intravenous route, IV route, and we plot a second curve. Now, after we have plotted these two curves, what we simply do is we find the area under the curves, right? The area under the curves for both when we administer the drug, orally, divided by the area under the curve of the graph, after we administer the drug intravenously, and then multiply it by 100. Simple. And this calculation, gives us the bioavailability of the particular drug. Okay, so this is a very important Viva question, as well as it is often asked as a part of your long question in your university examination, right? So the definition is important, the IV route is important, and how we find the bioavailability of an orally administered drug is also to be noted. Okay, now what are the measures of bioavailability? As we can see, this is again a serum concentration, versus time curve of a drug administered, right? Now, what can we see from this, from this curve? See, first of all, very importantly, we can see the area under the curve, right? This is the area under the curve of the of the drug. Okay. Now, this is T max. Now, what exactly is T max? So, first of all, the first parameter or the first measure of bioavailability is area under the curve. Number one. Okay. Now, number two, what we have is T max. Okay. Number one is area under the curve. Okay. Number one. Second one is what? Second one is T max. Now, what exactly is T max? T max is the time required for the for the drug after its administration to attain maximum plasma concentration within our bodies. Right? You have read this, these curves before in biochemistry as well. So I don't think you should have any problem in interpreting them. So as like we had studied in biochemistry, T max, and there is maximum safe concentration or C max, which is our third measure. Okay. So we have the three measures of bioavailability. What are they? They are area under the curve of the graph. There is type T max and there is C max. And what exactly is C max? C max is the maximum safe concentration of the drug in our plasma. Okay, so these are the three measures of bioavailability. Okay, and again, as I told in the previous slide as well, there's 100% bioavailability of drugs which are administered via the intravenous routes. Okay. Okay. Now this is another curve, which are often asked to interpret both in your Viva tables, and you can include them within your theory answers as well, to beautify the answers first. Okay. So let us read this graph. This graph gives us the plasma concentration versus time curves for three preparations. Okay. Now these three preparations or formulations can be of the same drug, or it can be of the different, or it can be of different drugs as well. Now, what we can read from this graph is, see, this formulation B which we have over here, okay, formulation B, okay, formulation B, as you can see, it is being absorbed over a longer duration of time, right? It is being absorbed over a longer duration of time when we compare it with both preparations A and preparation C, as is very obvious from the curve, okay. Although, if we see properly, the net absorption, or the net absorption or the net utilization of both preparations B and A in our body is same, because if we calculate the area under the curves for both preparation A and for preparation B, we will get the same area under the curve. Okay. However, what we may see is, see, B, the curve B or the prep, or the formulation B is not attaining the therapeutic concentration. Okay. Now, this therapeutic concentration is the minimum concentration of the drug. Okay. The minimum plasma concentration of the drug, which is required to bring about a therapeutic response. And by that, what do we mean? I mean that the smallest, or the minimum amount of drug which is required in our plasma to carry out the beneficial effects of the drug. Now, as we can see very clearly, B is not attaining this minimum therapeutic concentration level. Okay, and neither is C. Okay, and neither is C. And C, as you can see, C also has a smaller, area under the curve, right? So its bioavailability will again be less. So the most beneficial of the three, as you can see very clearly, should be A, right? A is the most beneficial of the three. Why? See, it has the same, the formulation A has the same area under the curve as B, okay? And firstly and secondly, or most importantly, what it is doing is, it is getting, above this minimum therapeutic concentration level, okay? So this is covering this much gap between the therapeutic concentration, so it is crossing the therapeutic concentration of the drug. And hence, A is the most likely to bring about the desired therapeutic response. Okay, and I hope this graph is clear, and this graph is again taken from KD Tripathi. Okay, what are the factors affecting bioavailability? There are physiological factors and the physicochemical properties of the drug. Both of these factors, affect the bioavailability of a drug, of a drug. And as you can read, very clearly, there are certain factors like the pH of the stomach, surface area of the intestine, so on and so forth. And in the physicochemical properties of the drugs, as you can see, there is water and lipid solubility, there is pKa, molecular size, so on and so forth. And I won't necessarily lengthen the video uselessly, because you will be getting the PPTs in our website. You can download the PPT from there, and you can refer with my lecture, so that you can study in a more effective manner. So I won't spend time reading out my PPT uselessly, and in areas where which don't require understanding, and uselessly lengthen the video. Okay, so let's move on. Okay, one more important topic which we are often asked in our, as a short note is first pass metabolism of a drug. First pass metabolism of a drug. So what do we mean by first pass metabolism? Okay, so drugs that are absorbed via the GIT are circulated to the liver via the hepatic portal way. Okay, so after we ingest a drug, this drug, or this chemical preparation is taken to our livers via the hepatic portal vein. Okay, after it is taken over there, now our little liver is acting as a filter. And what does it filter out? It filters out the unnecessary portion of the of the drug which it deems to be surplus for our needs. Okay, it filters that portion out, and then what it does is the other part is circulated systemically, or it gets into a systemic circulation. Now this combined effect, or this entire process is called as the first pass effect. Okay, and this is again a very beautiful diagram, which you can include in your answers. Okay, and you will obviously be getting extra marks for this. So this is the liver, and as you can see, this is why the common bile duct, and this is the hepatic portal vein via which the drugs is getting, drugs are getting into the liver from our gastrointestinal tract. Okay, and what is the sites? What are the sites? As I told you, the sites are the liver, the gut wall, and the lumen. And what does our first pass metabolism result in? Our first pass metabolism results in lesser bioavailability and shorter duration of the action of the particular drug. Okay, so more is the first pass metabolism, lesser effective will be the drug in our body. One more important topic, which is again important for your short note, for your short notes, I'll write short note, is apparent volume of distribution. So what exactly is this apparent volume of distribution? So this apparent volume of distribution is the hypothetical volume of the body that would accommodate all the drugs when these drugs are supplied if the concentration throughout was as same as that in the plasma. And what I mean by this is, it is a hypothetical volume. Okay, this apparent volume of distribution does not exist in reality. Okay, and this hypothetical volume of our body would accommodate all the drugs which are administered to us, but there's one catch. And what is that catch? That catch is that the concentration of the drug must be same throughout as that in the plasma. Okay, we get apparent volume of distribution by this formula, which is given by dB by Cp, where dB is the amount of drug in our body, okay, and Cp is the plasma concentration of that particular drug in our body. This is a very a nice simple illustration, again taken from KDG Party, where you can see clearly that although we are administering what do you call it, amount of drug which is approximately 1000 ml. However, the plasma concentration that the drug is effectively attaining in our body is 50 ml only. So by simple mathematics, as I told you, dB by Cp, we get the apparent volume of distribution as 20 liters. Okay, so this is again a very important short note and is also a candidate for your Viva questions. Okay. One more important short note. This is again a short note. Okay, so this is redistribution of the drugs. So what do we mean by redistribution? So there are some drugs which are lipophilic. Lipophilic matlab lipid loving, and these drugs show this property of redistribution. So once these drugs are administered, they enter into our circulation, and as we know, once the drugs enter our circulation, it will obviously reach the highly perfused organs first. Highly perfused means the organs where which are very richly supplied with blood vessels, right? Like our brain, our kidneys, our heart. Okay, richly perfused organs, and then the drug will move out from there and then reach the sites of low perfusion. For example, adipose or fat tissues, and these are the sites where there will be finally there will be termination of drug action. This entire cascade, this entire flow chart, as you can see, gives us the redistribution of the drug. Okay, and and a drug which undergoes high amount of redistribution is thiopentone sodium. Okay, always remember examples. Never forget to give examples with your short notes. Examples are very important, my friend. Okay, let's move on. Plasma protein binding of drugs. This is again a very important short note and a very important viva question as well. This is a must study. So what exactly is the plasma protein binding of drugs? So what exactly are these plasma proteins? These plasma proteins are nothing but they are macromolecules which are present within our blood. Okay, we have these particular macromolecules. Now after we administered our drugs, this drug goes and it binds with our macromolecules which are the plasma proteins. Okay, now as we know via the physicochemical properties of drugs can be of two types. They can be either acidic or they can be basic. Now if my drug is an acidic drug, it will bind to albumin, which is its designated plasma protein. Okay, whereas if my drug is a basic drug, it will bind to alpha 1 acid glycoprotein. Okay, so now my drug comes, it may be acidic or basic, and it binds with my plasma protein, which may be either albumin, as in case of acidic drugs, and if it is basic, it will bind with alpha 1 acid glycoprotein. Now, what is very important to note in plasma protein binding, my friends, is that after my drug has bound with a plasma protein, it will be rendered pharmacologically inactive. And what do I mean by that? I mean that this entire preparation of this complex or the drug and the plasma protein will not have any therapeutic activity of its own, right? So what is its use? So now this compound or this complex together in combination will serve as a reservoir for this particular drug in our body. Okay, now as you can see, this is also a very important part. What exactly is the significance of plasma protein binding? So what exactly what effect does it have on absorption? As we know, greater is the plasma protein binding of the drug, lesser will be its absorption, right? Because after it is being bound, it is again becoming pharmacologically inactive. So how will it be absorbed in our body? So more is the plasma protein binding, lesser is the absorption. Number one. Second of all, distribution. Distribution will always will also be reduced. So plasma protein binding will obviously reduce the distribution of the drug as well. Because it is bound. And metabolism. Plasma protein binding also decreases the metabolism of the drug and enhances the biological half-life. And how does it enhance the biological half-life? Like I told you, it will be acting as a reservoir for that particular drug within our bodies. Okay, so I hope this plasma protein binding thing is clear. This is a very important topic for your vivas and as a short note. Okay, now we come to very important portion in pharmacokinetics, and that is biotransformation. Now this is a long question candidate, my friend. So hear very carefully. So how do we define biotransformation? Biotransformation is the chemical alteration of the drug within our body. Okay, and what does it do? It renders non-polar lipid soluble drugs of our body into polar lipid soluble compounds, and then polar non-polar lipid soluble and polar lipid insoluble compounds. And once it is lipid insoluble, that means it will be water soluble, right? And once it is water soluble, it will be excreted via urine. Okay, it is obviously not reabsorbed and is excreted via urine. Okay, so so I hope you understood this. So what is the site for biotransformation? Our site is our very cute meditating liver. Okay, so this liver is our site for biotransformation. Okay, let's move on. Now, what are the factors affecting biotransformation? Obviously, we have age as a very important factor, because if you administer drugs in patients, or in patients of the pediatric age group who do not have a very well developed liver, okay, it will result in something as we call as the gray baby syndrome. As you can see clearly, this baby, or its mother, was administered chloramphenicol, which is an antibiotic, and after it was administered, so it developed a gray baby syndrome. And why is it so? Because after being administered chloramphenicol, because of its poor underdeveloped liver, this baby unfortunately could not metabolize or biotransform that chloramphenicol within its body, which caused toxicity. And this poor baby had to suffer from gray baby syndrome. Other factors include dietary habits and pharmacogenetics and simultaneous co-administration of drugs. Okay. One more important thing, this pharmacogenetics part, alone is a short note candidate. Okay. And what do we mean by pharmacogenetics? Pharmacogenetics means nothing but the inter-individual variation of the effect of drugs, in a particular population of people, which is due to its genetic, which has a particular genetic basis. As you can see in this diagram, we administered a drug to a particular, study group of patients, and after some time, when we go to check the results, we are surprised. And why are we surprised? Because see, we intend to make the drugs useful for therapeutic purposes only, right? But what we very surprisingly observe is that different groups of different subgroups of patients within this huge group, okay, is suffering from various different effects of the same drug, which is given in the same dose and with the same prescription, okay, and these patients also have the same diagnosis. So why is this drug having these all these different sort of effects in the different groups of patients? So the basis for this is nothing but pharmacogenetics. Pharmacogenetics, like I told you, my friends, is also a very important candidate for short notes and is a viva question as well, so study it properly. Okay, so what are the outcomes of biotransformation? An active drug can be turned into an inactive metabolite, or it can be turned into an active metabolite, and finally it can, an inactive or a pro-drug can be transformed into an active metabolite. Okay. What are the phases? Again, this is also very important viva question. So biotransformation has two phases. You can read, this in this different, format in this table as is beautifully shown, and you can also inculcate this table within your answer. Okay. So go through this table. I won't prolong by reading this out. Okay, this is very simple, nothing to explain in here. Now make sure you inculcate this in your answer. Okay, my friends, one more very pertinent question in here is that what particular order does a drug follow while it is undergoing biotransformation? Well, I would like to tell you that there is no particular thumb rule. Is that every drug which we administer to a patient will undergo biotransformation in a specific order. And by specific order, I mean, like for example, here see, after the drug is being administered, it is undergoing phase 1, phase 2, and finally it is being excreted. Most drugs which when administered in a body follow this particular order, but it is not same for all of the drugs. Some drugs, after it is administered, may undergo either phase 1 or phase 2 only, and then undergo excretion. Or very importantly, some drugs like phenytoin first undergo phase 2, then may undergo phase 1, and then excrete, and then are excreted from a body. Okay. Or there are also some culprit drugs which are not particularly metabolized in our body, drugs or chemical compounds which do not undergo metabolism, within our bodies and are excreted unchanged. Okay. One more important short note, and a candidate for viva question is microsomal enzyme induction. So what exactly are microsomal enzyme inducers? So we have these certain drugs, drugs or insecticides or carcinogens, which interact with the DNA in the hepatocytes, which is our liver cells, and increase the synthesis of enzymes, which are known as microsomal enzymes. And most importantly, these enzymes are cytochrome P450 and glucuronide transferase enzyme. Very two important enzymes which are induced by these certain drugs. Okay, and how is it done? So this is done by either enhancing the rate of synthesis of the enzyme or by reducing the rate of degradation of that particular enzyme. Okay, and see one very funny mnemonic, which will help us remember the P450, enzyme inducers, the drugs which induce P450 enzyme, are Barb's funny mom refuses greasy carbon shakes. Okay, so Barb stands for phenobarbital, funny stands for phenytoin, mom stands for modafinil, R stands for rifampicin, so on and so forth. So this is just an example of a few drugs you can remember. You can remember, choose to remember only two or three of these drugs, but remember to inculcate them with your answers. Okay, so this is what our microsomal enzyme induction stands for. Okay, so after our enzymes are induced, right? So what effect does it have? Why is it clinically relevant? Okay, so after the metabolism, after a drug goes and induces the the enzymes within the body, it will reduce the efficacy and potency of the drugs, right? Because these drugs, which were supposed to be within our bodies for a longer duration of time, are being metabolized and excreted faster, because they are suddenly going into our body and excreting, synthesizing all these enzymes, which is rapidly metabolizing these drugs and excreting them. So the efficacy and the potency of the drugs will come down. What more will come down? Will the plasma half-life will obviously come down, and duration of action, because it is being metabolized faster. Drug tolerance will increase. That means you will require more doses of the drug. To if you want to bring about the desired therapeutic response within the patient, right? Moreover, it will also increase drug toxicity, right? Why will this be so? Because these drugs will undergo metabolism so quickly, right? So the metabolites or the products of metabolism of these particular drugs will start accumulating within our bodies, and these metabolites will be severely toxic, and hence will cause drug toxicity. It will also increase chances of drug interaction, right? Because if I administered a drug before, and that is not particularly metabolized or very quickly metabolized from our body, and then again if we have to take some other drug, these two drugs may have very severe harmful interactions within our body. Okay, and it can also alter physiological statuses of an animal due to the altered metabolism, which is very obvious. This is a flowchart which gives us the outcomes of cytochrome P450 induction. You can read it. For example, see, there is decreased drug level, which can cause a risk of therapeutic failure, or it can also cause increased drug level, which is helpful for us, and finally giving us the desired therapeutic response. Okay, after we are administering a cytochrome P450 inducer, that is, right, so that it can increase the drug level. Okay, one more very important topic, which is a short note and a part of a long question and your Viva candidate, so you can understand how important this is. Okay, this is the excretion of the drugs or the clearance. Okay, so what do we mean by clearance? Clearance, as the term suggests, is clearing out the drug from a body. So it is a fixed volume of bodily fluid which is cleared of drug per unit time. And what do I mean by that? What I mean by that, it is a fixed volume of the of our body from which the drug which I'm administering is being removed in unit time. Okay, so this is a formula which gives us the clearance of the drug, which is drug elimination rate divided by the plasma concentration of the drug. Okay, remember this formula. You need to, you need not remember anything else much from here. And as you can see, this figure is again giving us very big, beautiful illustration of how the drug is cleared by the kidney after it is being administered, 500 grams. Okay, the volume of distribution is 10 liters. Okay, so what do we mean over here? As when I say that the volume of distribution is 10 liters, what I mean is over here is that the drug that is 500 milligrams of the drug that I have administered will be removed from 10 liters of volume of bodily fluid after it is being administered. Okay, and after it is filtered, your kidney will give a clear volume of fluid per unit time of free drug. Free drug, by the sense, after it is cleared out, the drug is called as a free drug. Okay. Yes, this is again a very important topic as well. What are types of elimination of clearances? As you can see, we have two types. One is a zero order and the other is a first order. This is again a very good, very beautiful difference, or between the first order and the zero order kinetics, which you can go through. I won't prolong the video uselessly, read through it. Now what I will tell you over here is to remember that F stands for first order, right? F stands for first order, and what does F also stands for? F stands for fraction. So always remember, in first order kinetics, a particular fraction of a drug will be excreted in unit time. Okay, like as you can see, this is a this is a graph showing us the first order elimination of a particular drug, and as you can see, there's 5 units which is being excreted for in the first hour. In the next hour, it is 2.5 units, right? So we are reducing the drug with a constant fraction of half. Okay, and finally we have 1.25 units per hour. Okay, and in case of zero order kinetics, a constant amount of drug will be eliminated in unit time. Like as you can see, 2.5 units per hour, 2.5 units per hour, and 2.5 units per hour. Okay, so a constant amount, that is 2.5 units per hour, is being eliminated. Okay, this is very simple. There's no confusion about this. And this graph, as you can see, is also a sloping straight line, whereas this is a curved one, right? So this is a very important topic for your Viva as well. Where you often asked to differentiate between first order and zero order kinetics. And this again is a part of your clearance. Okay. And any special mentions? Okay. There are also certain drugs, what we suppose, like what we used to believe is that a drug, after it is being administered to our body, will obviously, either follow zero order or will follow the first order kinetics. But it is always not so, my friend. In case of drugs like warfarin, theophylline or aminophylline, and phenytoin, as you can see, phenytoin is a very, shaitan, or is a very clever or a very cunning drug, as I may say. And why is it so? Because as the concentration of these drugs start to reduce, the kinetics of these particular drugs change from first order to zero order. Like first, after they were being administered, they were following the first order kinetics. Now as they are being metabolized, their plasma concentration is coming down. Okay, and as it does so, it is being, the elimination will switch over to a zero order kinetic type of elimination. Okay, and remember the examples: warfarin, phenytoin, and aminophylline. Okay, and what clinical significance does this have? As a result of this, the plasma concentration of these drugs increases disproportionately with an increase in dose of these drugs. Okay, so after we are administering the drug, the plasma concentration will have an uneven increase, right? Why? Because first it was following first order kinetics, it was all well and fine. The concentration of the drug was rising slowly and slowly, but then again, when its concentration reduces, it suddenly switches over to zero order kinetics. So obviously we'll have a disproportionate distribution of the plasma concentration of this particular drug. Okay, this is again a topic from from which we have also studied in our class 12 and in biochemistry as well, which is plasma half-life. Plasma half-life is the time required for the concentration of the drug in the plasma to decrease to 1/2 of its initial value. Okay, after the peak has been reached, like after we administered the drug, the time attained for the drug to attain half of its plasma concentration, half of its peak plasma concentration, I'm sorry, is called as P half. Okay, plasma half-life is also called as P half. Okay, and it is obviously a useful parameter which is derived from volume of distribution and clearance. As you can see over here, the half-life of the drug is 7.2 hours. It is calculated from the graph. You need not to see the calculation, but what you need to understand is this is the area where the plasma concentration of this particular drug lies, because 50% of the drug is attaining 50% plasma concentration of the drug is being attained in this time. Okay, this is the only thing that you need to remember about plasma half-life. No need to go into unnecessary details. Okay, now target level strategy. Okay, this is one more very important thing. So what do we mean by target level strategy? So after we have administered a drug, okay, we know that our patient is ill, and so we set a target, right? So we set a target as to the duration during which our drug which we are administering must reach a minimum plasma concentration in the body of the patient, so that it can quickly produce its therapeutic response. Okay, so after we are administering a drug, we are usually expecting the drug, right, to be effective and act as quickly as possible, and bring about therapeutic response at the quickest. However, it is always not the case. As you can see, drugs with a longer half-life, will accumulate in the body, right? Because they are, they are long acting, so they'll accumulate within our body. So if we don't adjust our dose of that particular drug in accordance with the need, it can cause severe toxicity within that patient. Okay, as you can see, it is producing toxicity later on. Okay, so to attain this target level strategy matlab target to attain our target of this plasma concentration of the drug that we're administering, we follow two modalities. One is the loading dose and the other is the maintenance. I'll come to the maintenance dose later. Now first, what exactly do we mean by loading dose? Okay. For example, drugs which have a higher, amount of, plasma half-life, that is, it is taking a very long time to attain its, desired therapeutic concentration in the blood. So, but our patient is very critical. We need to treat him or her as quickly as possible, right? So, what will we do? We will administer one single large dose of that particular drug. Okay. Or what we will do, we will administer multiple doses of the drugs, within a short span of time. And why will we do so? We will do so as to ensure that our target plasma concentration level of the drug is attained at the earliest and the patient can be saved. Okay. And there is this formula of loading dose which is given by Cp into Vd divided by F into S. Okay. So you can neglect this S fraction, and you need not write it within your answer. You just write F. So Cp, okay, C into V divided by F. Okay, and C stands for desired plasma concentration of the drug, V stands for volume of distribution, and F stands for bioavailability of that particular drug. Okay, so this is how you calculate loading dose, and you quickly attain your targeted plasma concentration. And then what is the maintenance dose? Now, after we have administered the loading dose, say, okay, now, our body will obviously metabolize the drug, right? So as our drug will be metabolized, its concentration will start reducing. And as its concentration starts reducing, so will its therapeutic action, right? Isn't it so? So to ensure that this therapeutic, level or the therapeutic response of the drug is unhindered or unaffected, we will ensure that a maintenance dose is given and is continued, so that this targeted therapeutic concentration of the drug is ensured or is maintained within our plasma, and we can have the therapeutic response as quickly and effectively as possible. And there's again a formula to calculate maintenance dose, which is Cl into Tc by F, where Cl is the clearance, Tc is the target plasma concentration, and F is again the bioavailability. And we multiply it with the dosing interval, which is given by psi. Okay, this is one more formula, and this is again comes as a short note or is a very good viva candidate as well. Let's move on. Okay, so the final topic for the day is therapeutic drug monitoring. Okay, this is again a short note and is a very interesting, clinically relevant topic. Okay, so what is therapeutic drug monitoring? Now, after we administer a particular drug, in case of some drugs, I'll come to what these drugs are later, we must always, monitor or ensure that we keep their plasma concentrations, under constant surveillance. Okay, and why do we do so? After we administer a drug to our patient, okay, now we have in our minds an ideal patient, or an average patient, or an ideal patient in whom after we are administering the drug, that particular drug in that dose, will bring about so and so response. But then, medicine 1 plus 1 is never 2, my friend, and we see that our patient is behaving completely different to the drug. And why is this so? Maybe his body is not being able to metabolize the drug well, maybe he has developed tolerance to the drug, or maybe the drug is turning out to be too toxic for him. So to ensure such mishaps don't happen in our day-to-day practice, what we ensure is therapeutic drug monitoring. And we constantly monitor the plasma concentration of the drug Now I will come to what and and we titrate or we adjust the dose of the drug in that particular in accordance with that with the needs of that respective patient. For example, as you can see over here, the suggested dosage treatment is being reduced to 800 milligrams. Okay. Now, what are the drugs, or what are the indications of therapeutic drug monitoring? They are the drugs, in whom the relationship between dose and plasma concentration is unpredictable, as I told you, Ferinton, because it can follow different, because it follows two different types of eliminations. So it will be very difficult, to understand what kind of an effect it will have on the patient. Second of all, and very importantly, drugs having, a narrow therapeutic window, that is drugs which in which the therapeutic concentration and the toxic concentration of the particular drug, there is not much difference in that. So we have to always monitor them. Second of all, drugs with a steep dose response curve like theophylline, and drugs with saturable metabolism like phenytoin, again like I told you. Okay. And then there's also importantly drug interactions, where we are administering another drug which can alter the metabolism of our first drug. Okay. In those cases as well, we must also ensure therapeutic drug monitoring, and the other indications you can read through my PPT as well. Okay. And most importantly, if there are indications, there are also contraindications, right? And what are contraindications? Drugs having wide therapeutic index. Okay, so if the difference between the toxic concentration and the therapeutic concentration of the drug is not much, we don't need to uselessly bother with therapeutic drug monitoring. Okay, and in drugs where toxicity is not a realistic concern, that is in drugs where toxicity is not very prevalent, we need not do so. Okay. And there are others, the effects of which can be measured using functional laboratory tests. For example, in case of anticoagulants, you can assess the patient easily by the compliance or the effect that the drug is having on the patient by simple blood test as well. Okay, so on and so forth. You can read the other points. Yes, so these are contraindications you must keep in mind for therapeutic drug monitoring. Okay. Now, what is the clinical significance? Now, therapeutic drug monitoring is very important because it helps us to maximize the efficacy of the drug. Okay, it helps us to avoid toxicity, like I told you. We can identify therapeutic failure. And what do we mean by therapeutic failure? If a patient becomes non-compliant, or we are administering the drug, in a sub-therapeutic dose with respect to that particular patient. Okay, and then we can adjust the dose, like I told you. And this new dose is given by old dose into desired concentration, divided by the old concentration, and this is a formula which will help us to identify what new dose of the drug must be given to attain our desired therapeutic response. Okay, and hence it also helps us to facilitate therapeutic effects of the drug and then identify poisoning, toxicity, and also drug abuse. This is a very good diagram which is showing us the therapeutic drug monitoring in recent practices. Okay. So my friends, thank you so much for the patient hearing. I hope I was able to help you with these important topics for pharmacokinetics. Pharmacology, as I told you, my friend, is a huge topic, is a huge subject and is very volatile. But if you understand the concepts clearly with a steady mind and with some amount of patience, I am sure my friends, you will excel, and you will excel and you will shine bright. Okay, with that note, I would take your leave for today. And I hope to see you in my video lecture. My next video lecture will be on pharmacodynamics. So stay tuned and subscribe to Make Medical Easy for further such videos. Bye bye. Take care.